Good end-of-life care is about respecting people's lives and allowing people to live as meaningfully for as long as possible.
And we kind of look through the rearview mirror of our life and we start to realize, oh, that might be why I was exposed to that. Because now I see people like Mark and Rebecca that have this diversified portfolio, and you are navigating leadership challenges that are they're exponential.
The challenge is, how do you ensure that all employees feel like they're part of the whole, that they understand that the whole is greater than the sum of its parts?
I think there's so many opportunities that it opens up, and I think at the heart of all of that, it's about building as many possible connections into your community, and both taking advantage of those in a positive, ethical way to support the sustainability and the reach. So it's a really rich tapestry of networks that you're creating, as well as maximizing the business opportunities of that relationship with your community.
Welcome to our crossover show with Anatomy of Leadership and TCNtalks. Now, here's our host, Chris Como.
Hello and welcome to the Anatomy of Leadership. I am super excited today for a multitude of reasons. First off, we have a returning guest with us, Rebecca Ramsay, who's the Chief Executive Officer of House Call Providers in Portland, Oregon. How are you, Rebecca? Good to see you.
I'm good. Happy to be back.
Yeah, exactly. So Rebecca's back. So the fact that she's back, there's not a lot of guests that we have on a couple of times, but really good guests we do bring back. And so, but there's something that Rebecca and I talked about in the green room in our podcast together when we talked about home-based primary care, because she has a very unique program. And one of the things I bumped into is that Rebecca has a very diverse organization. There are multiple service lines. And I just said out loud, Rebecca, I bet there's a lot of leadership challenges. And she said, boy, there are a lot of leadership opportunities, challenges. And then this leads me to our second guest. And this is the first time we've had two people on a podcast at the same time. And so welcome to Mark Jarman-Howe. And so Mark is the Chief Executive Officer of St. Helena Hospice based in Colchester, England. So Mark is also our first international podcast guest as well. Good to see you, Mark.
Hi, Chris. Lovely to join you both. Feeling very privileged to be first international guest and get to be on with Rebecca. So that's great.
Yeah, and I tell you what, Mark, we're going to let you go first. In a second, what does the audience need to know about you, maybe at a personal level? But why not first just tell them about your program? Because like Rebecca, you have a very diverse organization that you oversee in England.
Yeah, so it's probably worth just very briefly sort of saying that the sort of funding model for hospices in England is very different to the States. So the NHS, the National Health Service, which sort of is very much similar to sort of Medicaid, Medicare type programs, funds about a third of the cost of providing hospice provision in the UK. And then the rest is generated from charitable sources, so philanthropy and sort of income generation by the providers themselves. So St. Helena provides a integrated model of hospice and palliative care, which is fairly typical in the UK. We don't make quite the same distinction, and we're not funded on that separation between hospice in the last few months of life and then palliative care from the point of diagnosis. We don't really make any meaningful distinction. So our starting point is a very integrated model of hospice and palliative care. But because of funding pressures that we've been facing, we've taken that a number of steps further. So we've moved into last years of life. We provide a number of other non-hospice services around community nursing and home from hospital type care that's nothing to do with end-of-life care, but plays to the same values and strengths of holistic care. And also because of the reliance on charitable or philanthropic sort of income for what we do, we've also moved into some interesting commercial ventures to try and diversify and minimize the risk around those sources. So as well as sort of hospice care, we have a cleaning company, we have a very large number of thrift shops, and we provide lotteries and a range of other activities as well, including some private care provision as well. Personally, my background was in the National Health Service before I came to the hospice, both as what you would call a payer, what we would call a commissioner of services, but mostly as a provider in large acute hospitals, but also with some involvement in community services.
That's great, Mark. And just maybe just anything personal that you would want the audience to know. One of the things I just loved about you is that, even though in the UK, we have such common just values and passion for this work. And so I immediately just gravitated towards that when I met you. But anything along those lines you'd want our audience to know?
Well, I think interestingly, when I first got sort of engaged in end of life care was in my first career, which I spent the first 10 years after leaving university in prisons, working, I should say. But yeah, I started on a graduate scheme as in the prison service in Britain. And one of the projects I got to do in the career was working with people who were going to spend the whole of their life serving their sentences and therefore, of course, were going to die in custody. And that really got me thinking about bringing together all these stakeholders across a number of sort of prisons about how do you balance dignity and care with the fact that they also need to serve their sentence and they need to be, we need to keep the public safe in how we do that as well. And that just struck me as what a fascinating area in terms of sort of respecting individual dignity and sort of understanding the nuance and the subtlety of end of life care in a very complex sort of high risk environment. And all the way through the health jobs that I've done, long-term conditions, palliative care, end of life care has been a sort of a running theme. And I think what really strikes me is all of it comes back to good end of life care is about respecting people's lives and allowing people for sort of to live as meaningfully as for as long as possible. And it makes you as a person involved in that think about your own values in your own life as well. So hopefully that's a little bit of an interesting fact. There aren't many hospice leaders in the UK with a prison service background.
That's actually really good.
We could learn so much from just what you talked about. I mean, we need to be doing so much more of that in the United States. There are some pretty amazing hospice prison projects or initiatives that are going on, but I think it's a little bit of a one-off and not nearly probably as prevalent in our country. So that's fascinating.
Yep. You didn't know this, Rebecca, but it'll be a good cliffhanger for our listeners. We are actually the very first prisoner from the Angola Project is actually going to be on our podcast. And so his name is Stephen Gardner. When the new warden had got to Angola prison in Louisiana, which is a very hardened place, and the Angola Project is kind of the model, if you will. And you're so right. There's so far to go in the States, but it was kind of the initial. And so he was the initial prisoner that the warden went to. And he's got a beautiful story of just his whole redemption of his own life in that program. So to be coming, that's actually a podcast we're actually taping in a couple of weeks. So Rebecca, so to you now. So what do you want our audience to know about you? And then I'm going to tie this together. I'm just so excited about this because you both have so much diversity that you oversee as a leader. And I think there are going to be so many lessons. But what would you want the audience to know, Rebecca?
Yeah, so the organization that I'm leading is House Call Providers, and we're based in Portland, Oregon, and we serve patients really across the state, but our biggest concentration is in the Portland metro region. And we, a little bit uniquely from some of the other hospice organizations, nonprofit hospice organizations in the country, we actually started 30 years ago. We're celebrating our 30th year right now, serving our community. Started as a home-based primary care program, which is basically, forget about going into an exam room or a clinic to get your primary care. You actually have a doctor or a nurse practitioner and nurses and social workers, even a chaplain, sometimes a clinical pharmacist who actually comes to where you are. Whether that's in a private home or in some kind of memory care or assisted living facility or senior living community, and we provide comprehensive primary care in those locations, primarily for individuals that have mobility challenges or significant chronic diseases that make getting out of the home really challenging. So certainly we don't serve everyone with this model. It's expensive. And so we're really focusing on those individuals that without our care would not be, maybe frequenting the emergency department or the hospital for their care. And then about 15 years ago, we recognized the opportunity to expand our service model and include hospice. At that time, we developed these pretty intense relationships over time with not only the patient, but with their family and caregivers. And about 25% of the patients we were serving in primary care each year would go on to die. And so we would be referring these patients after having this very comprehensive and deep relationship with them to an outside hospice agency. So we thought, well, wait a minute, why don't we keep them with this family, this clinical family that they know and trust? And so we opened a hospice 15 years ago. And then that led us to recognize, what about patients that are kind of in between? Those individuals who have serious or advanced illness, they may have progressive end-stage cancers, but they're not actually hospice eligible because they may live longer than the 6 months, which is what our reimbursement model pays for in the United States for hospice. So we opened a palliative care, community-based palliative care program. That program is unique because we actually serve a lot of low-income Medicaid individuals in that program. And we have about 20% of the patients we serve in that program have housing instability. So our teams are actually quite used to going out on the streets, into shelters, et cetera, and serving patients who otherwise would possibly be dying on the streets with very little support. So we have kind of a national recognition for the kind of palliative care team that we've developed in order to serve that population. So that's a little bit about house call providers.
That's really good, Rebecca. So that really gets to the point of why I thought this would make a fascinating show. My guess is you could probably sit here. I know long form podcasting, the few people that will listen to a 4-hour podcast, I have no doubt we could do a 4-hour podcast with each other. But we have so much to cover. What I wanted to center that, my job is to be thinking what's next. We get so much feedback about, we love your podcast because you guys are always pushing the envelope of what do I need to be thinking about? And Rebecca, I give you all the credit. You and I were in the green room and I just said to you, I'm like, Rebecca, that continuum you just talked about, I don't think most people realize that sounds awesome. Let me go do that. But the leadership challenges of overseeing that type of organization, we've gone from basic math to like trigonometry, if you want to use an analogy. I'm blessed so I grew up in the business world. So KPMG, Pete Warwick, and a Fortune 50 company. My second job, the company was modeled after General Electric. And most people know who Jack Welch is. He's got, all this interesting reputation. What most people do not realize that one of his superpowers was building an organization over a very diverse portfolio of businesses. Yes, the brand was General Electric, but it was a portfolio of businesses. And, we kind of look through the rearview mirror of our life and we start to realize, oh, that might be why I was exposed to that. Because now I see people like Mark and Rebecca that have this diversified portfolio, and you are navigating leadership challenges that are they're exponential. And I don't think the lesson is Mark and Rebecca have challenges that no one else could overcome. That's not the point of today. They do have some incredible challenges. And what is that Chinese term? If you want to go in the journey, ask someone who's coming back from it or someone who has been there is the gist of the journey. And that's the spirit of the questions today.
Thank you to our Anatomy of Leadership sponsor, Dragonfly Health. Dragonfly Health is also the title sponsor for Leadership Immersion courses. Dragonfly Health is a leading care-at-home data, technology, and service platform. With a 20-year history, Dragonfly Health uses advanced technology and robust analytics to manage durable medical equipment and pharmaceutical services as part of a single efficient solution for caregivers, patients, and their families. The company serves millions of patients annually across all 50 states. Thank you, Dragonfly Health, for all the great work that you do.
That's just a perfect place, I think, that I want to jump into. So here's my question. And maybe each time we'll have Rebecca go first and Mark go second. And then, of course, any kind of comments you guys want to make afterwards. But what unique leadership challenges arrive when moving from a single service organization to managing multiple service lines under one organization? So that's my first question.
That is such a big question and so important. And I have so many answers to that, but I want to start with The one challenge that I think sort of stands above all the others, that to me feels kind of like a make it or break it challenge, and it's really about culture, and it has a lot of trickle down effects. So the challenge is, how do you ensure that all employees feel like they're part of the whole, and that they understand that the whole is greater than the sum of its parts. So to make that really concrete, we have 3, soon to be 4 individual service lines that are all complementary, and ideally they make up this really beautiful continuum of care for patients who have serious or advanced illness or are struggling to get out of their house. But what we need is that, as an example, we need every hospice employee, so a hospice aide or a case manager or spiritual counselor or a social worker that works in our hospice line of business, should also deeply understand that when they are going into a community, when they are serving a patient in a memory care facility, and working with a patient or a family member or even a resident manager at one of these facilities, that what they do and how they conduct themselves has an impact not only on the future census of our hospice, but also on the potential growth opportunity or relationship that we might be planning to have with that family or with someone they know, a friend, or with that facility for our primary care program. Conversely, we need our primary care team members to feel responsible, not just for their own program and how it's growing and how we're maintaining, panel sizes where they need to be, but also that what they do means, the difference between a hospice average daily census of 150 or 110, because those patients that we're serving in primary care, we hope we will be able to continue to serve them, and they will want us to serve them in our palliative care or our hospice program. So it's really about making sure that that everyone understands that we're all in this together, and that everything each individual employee does matters across the organization. And that is I'm sure Mark will agree with me that it is not an easy feat. It's a really big challenge, and you have to be very intentional about building your culture so that that's the outcome.
That's very well said, Rebecca, because it's so interesting. You're reminding me, Rebecca, listening to you. So I was the CEO of Four Seasons for a long time before we founded Telias. And we had a corporate office, and there was just a little road and then our inpatient unit. And one of our operation leaders said, you would swear that road was the Grand Canyon, the difference between the inpatient unit and the community-based staff. Mm-hmm. And you're like, you're kidding me? It's just a road. But the reality is, right, is that they're working in a different model, but yet they need to appreciate the sum of the whole, but they're living in an individual, whether it's an inpatient unit, a maid service in Mark's case. So, Mark, I'd love to hear your answer, because I'm sure it's going to be fascinating.
Yeah, and I think I'd sort of double down on the sort of the points that sort of Rebecca made. I think culture comes first and foremost. And I think if you can't tell sort of a convincing story about how this sort of breadth of service provision, the way I see it is you're building out in order to achieve greater integration for a greater population, but you need to be able to tell a compelling story about that aligns with the sort of the values, the vision, the mission of the organization. And I think if you can't do that, then I think you struggle with engagement and you'll struggle with sort of bringing people with you. I think interestingly, I've found that often with these challenges that telling that story internally is often more challenging than externally. So actually a lot of external stakeholders and partners are really receptive to new ways of thinking, new solutions, because all the challenges and the issues that we face as providers of hospice care, those challenges are sort of playing out on an even bigger scale within the sort of health systems as a whole. And if we think about the sort of demographic changes in our countries, and there's a lot of social issues as well as health issues. Rebecca's already touched on housing. So there's all those other issues that are playing out that everybody else is having to get their heads around. So what they're really interested in and quite positive about actually is when they see providers thinking differently and willing to go outside of their comfort zone and maybe start to find solutions and contribution to those sort of wider issues. So ironically, it's easier to get permission with some of those external stakeholders, including payers, than maybe it is in terms of bringing colleagues with you, because one of the downsides of the level of specialist expertise that you often get in hospices is they're so focused on the patient and the family in front of them and providing the best possible sort of holistic care, that taking a step back and thinking about all of those patients and families that aren't immediately in front of them, all of that unmet need, all of those sort of gaps and problems in the wider system that they could be contributing to, that's really hard for them to have their headspace and the sort of the time to think about that, as well as to really give that highly personalized, amazing, complex care. So I think there's something about navigating that. Some of that is around education and training. I think there are some very practical issues around workforce and capability and competency, that as you broaden the portfolio of programs and services that you're delivering, you need to think about your skills mix and the range of disciplines you've got within your organization. You've got to think about whether you grow that internally or whether you bring that in from outside. Do you do that through partnership or through acquisition or through merger, and all those sort of more sort of commercial sort of ways of thinking. And then I think there's also an implication for your back office and your sort of support services as well, that you are introducing another layer of complexity, potentially in terms of funding streams and billing and contracts. So I think it's really easy to sort of focus on where our passion is, which is, integrated, joined up, high quality services for a bigger population. But sitting behind that is a lot of detail and a lot of sort of commercial things that need thinking through very carefully.
That is so well said, Mark. I grew up as a hospice CEO. Telias is probably more like an association, a consulting group, and a clinically integrated network, none of which I grew up in. And so the idea of this was super cool. The devil in the details has been so complex. So I wonder what advice you might have, just because I'm thinking and putting myself in your shoes, like a lottery service and a cleaning service, and trying to paint the picture of a common cause and purpose of that. Any tips about that? Because I imagine that's a heavy lift.
It is, but also it's quite liberating. So it's I certainly would advise anyone thinking about sort of diversifying their income in terms of their non-clinical sources of income, to do that in a sort of a measured, well-researched way. But having said that, I think there's so many opportunities that it opens up. And I think at the heart of all of that, it's about building as many possible connections into your community, and both taking advantage of those in a positive, ethical way to support the sustainability and the reach of the hospice provision. So there's a really strong USP and message when we're selling our cleaning services to local businesses. This is their way of giving back to local hospice care, which they and their family may need at some point. So I think there's almost like a philanthropic message that you're using to generate business for your hospice benefit. But also I think you're creating opportunities for different conversations and for building death literacy, where we talk a lot in the UK at the moment, and at St Helena we're really engaged with public health approaches to palliative care and compassionate communities, which is all about building resilience, building understanding in the wider community about dying, death and bereavement, because then people are more likely to engage with advanced care planning. They're more likely to have open conversations with their family and professionals involved in their care. And then when they get to the stage of needing palliative or hospice care, they're better set up to receive that care, and the providers are better able to understand what they need and want, and then build a plan accordingly. And I think the more you can build those networks and those conversations through a range of different channels, the easier it gets actually to provide the hospice and the palliative care. But there is also an obvious commercial benefit, because you can then start to cross promote and cross sell across those. And you would be surprised at some of the connections that we've seen between a customer of the cleaning company then donating directly to the hospice, or then commissioning us to do some bereavement support training for their staff, or one of their colleagues then needing access to some of our care and support, and them recommending and that person being referred to us much sooner than they would have done if they hadn't been using us to provide their cleaning. So it's a really rich tapestry of networks that you're creating, as well as maximizing the business opportunities of that relationship with your community.
I love that word.
It's so interesting. Oh, sorry. I
figured this is going to be difficult because we're like going to be popping off of each other. This is so good. Yeah. But just his one word, and then Rebecca, I'll give you the rich tapestry is, to me, is such a beautiful word. Like, you've created this interesting ecosystem that's cross-pollinating each other. Go ahead, Rebecca.
I just wanted to piggyback on that a little bit, and say that, I'm afraid of creating, thrift stores are more common and that are associated with hospices in the United States. And we've talked about opening a thrift store, and it just hasn't been the right time. But one of the things that we have done, which is just another way at getting at this, broad, building that tapestry of networks and actually finding ways to get upstream in terms of the public health messaging and the education of the community around end of life, is that we, instead of having like a typical annual fundraiser every year, which we do that maybe once every 2 or 3 years, we've created a community engagement event. We just had it last weekend, where we host it, our organization hosts it, but we invite community partners from around the community that are serving a similar population with different services. So, for instance, there's an organization that is called Store to Door, and what they do is they go grocery shopping and then deliver meals to elderly people that can't get out of their home. We have a number of other services that are not directly healthcare, but that are really sort of, adjacent to what we provide. And we all get together and we put on this event in the middle of the summer in a park where communities are bringing their kids to go play at the playground. We advertise it on the morning shows, on a couple of radio programs. And so we get our network, our direct network of patients and families that know us, but we also just get the public coming through. And there's this area called Nonprofit Row, where all of the organizations or community-based organizations set up a tent with educational material, and they're there to talk to people who are just walking by. And it's been great. It's been growing each year, and it really does change the conversation, and it just helps us to make sure our community knows that we're here for them, and that, it's not just about one single organization. It's about all of these organizations coming together to support a population that really can be invisible at times.
That's so well said, Rebecca. In fact, I keep going back to this word that Mark said, of like a rich tapestry. The other word that's coming to me is an ecosystem. And I love that, because that's always been the heart of hospice, is collaborating with the community. But what strikes me is that, though you both made bold moves but this part of the ecosystem is the part that we need to own, lead, etc. So that maybe leads me to the second question. How do you balance then the mission, the margin, when you have different service lines, different payer mix or economic models, different regulatory frameworks, and then different operational demands? I'm fascinated to hear so maybe Mark, this time you go first, and Rebecca, you go second.
Yes, yeah. I mean, like Rebecca said in response to the first question, there's so many things you could say about that. But I think at the heart of all that, the pitch when I came into this job as sort of CEO at St Helena was unmet need. That was the thing I was passionate about. There was no doubt at all that people that were lucky enough to be referred to St Helena Hospice were getting amazing care and support. but the organisation was not taking responsibility for people not lucky enough to be referred to it. And just that sort of mindset shift about, okay, let's not compromise our care and our quality, and we've doubled down on our compliance and our education and our training and how we develop that expertise in-house, but actually let's spend as much time and effort on thinking about how do we proactively identify the population that's out there. We now use population approach to end-of-life care as the way that we describe that, which is a sort of value-based ACO type way of thinking. I would love for us to be funded as an ACO for this end-of-life population. Sadly, that's not happening at the moment, but it hasn't stopped us acting as if that were the case, because it's the right thing for people with those needs. So what we started with was proactively identifying people in the last year of life in the geography that we serve as a hospice, working with a range of other health and care partners to share information and to negotiate information agreements around that. We did a whole host of engagement with users of services, with family members, with residential care homes, with family doctors, with hospital doctors, etc. And we came up with 10 outcomes that matter most to people and their families in their last year of life. And we started to build a dashboard where we were pulling information from all these different elements of services that they were interacting with, so we could start to understand how far away were we from an optimal model of meeting all of the needs of everybody in the last year of life in our area. And of course, we're never going to get there in terms of delivering that for everybody, but as a way of focusing people's minds and aligning strategies and resources within a particular health system, it's been hugely powerful. And because we were very successful at mobilizing that engagement and getting people excited and passionate about that, what we found was we were getting a lot more people referred into our services. Unlike you guys, sadly, that doesn't mean more money coming in. It just meant that our costs were going up and we were having to work harder to close the gap. So that then almost meant that we had to go looking to diversify how we develop our income. So that's where we started to diversify on two fronts. One was starting to bid for and win what we would call contracts, but programs of care that are not hospice. So community nursing, elements of some of the primary care provision in the home that Rebecca's talked about, a lot of the home help and the personal care in the home, what we talk about in terms of social care. We deliver a lot of services, home from hospital, bridging support services, and all of that has been complementary to our skill set. We've been able to bring a lot in terms of our values, our ethos, our skills, our holistic approach to that wider population, but it's also generated a margin from those programs to reinvest in our mission to achieve the population approach. And then at the same time, we've diversified our commercial income streams, our cleaning, our lottery business. We had a arts and crafts business doing after school clubs, but again, all with a mission to build relationships at the same time as generating a profit to come back into the hospice. So almost by starting with that population approach, we had to then think differently. And then it's just sort of almost evolved quite naturally from there. And it's given us quite a broad portfolio, which is challenging, but also means that you've got lots of opportunities. And when one thing, maybe the wider circumstances are not right for that to progress, something else, there will be an opportunity. So you've always got something where you feel like you're taking steps forward.
Man, that's so rich. I'll make one comment, Rebecca. I'd love to hear your answer as well. But what strikes me, Rick, is listening to you is America kind of happened the opposite way. And hopefully my peers won't throw something at me in this podcast. We got a good reimbursement. I won't call it a rich reimbursement, but we had a good reimbursement. And then we diversified with more community services that maybe there wasn't reimbursement, or where there's definitely a lost leader. But now that our reimbursement is becoming challenged, a lot of our peers throughout the country are going, well, maybe we can't do that community bereavement the way we did it before, because all of those things we chassied were more lost leaders because it was the right thing to do for our community. Yours went the opposite way. It kind of feels like as you've described it. Yeah. How do you balance the mission and the margin when you have different service lines, different payer mix, different economic models, different regulatory frameworks, and different operational demands?
I think for our organization, what we have done to try and balance all of those is, again, really focusing on our organizational culture and developing values and behaviors that all of our employees can connect to and that reflect the mission and the vision of the organization. And then keeping processes and expectations really well aligned with those values, and always keeping the patient the focus, regardless of the service line. So one of the biggest challenges for us, and I know this is probably, similar for you, Mark, certainly Telios will understand this as well, is really keeping our workforce stable and resilient. And it's one of the biggest things that we actually compete on in our marketplaces. So we have, in many of our programs, we have more patient demand than we know what to do with, which is great. Like that's not always the case, but we're really fortunate. The problem is it's really hard to find workforce, particularly after the pandemic. It's just been so challenging. And so I really think about the benefit of our organization to the community is about how we treat our staff, how we keep them resilient, how we keep them focused on the patient and inspired to do the work and resilient to do the work. So I think, that's really how I look at this challenge, is like, I want to be the place that healthcare workers in our community come to, because they recognize, like, this is a place where I can breathe, I can do the work that really matters to me, I can continue to stay inspired. And having the multiple service lines actually does benefit employee resilience, because we have many examples of hospice nurses who have decided that, I'm a little tired, and hospice work it's really challenging, and you're dealing with a lot of loss. And they have decided to move to our primary care program, where they actually have, more patients to serve, but they're with those patients longer, and it gives them a break from some of that end of life bereavement that can get really heavy. So I think, there's a lot of strengths in having, as Mark suggested, in having the diversification, both financially, but also around employee resilience.
That is excellent. Yeah, there's a couple of things in just pearls in what you just said, Rebecca. I wanted to go back to one of them. You were talking about the processes and trying to keep some consistency. Is there a flip side to that? There's a whole school of thought about disruptive innovations versus sustaining, and you have to be careful putting the chassis of a more mature business on a more emerging business. Have you found that subtlety, that you want some consistency, but you have to be careful it's not completely consistent because of the different businesses at their very lowest common denominator are not the same business? Does that resonate?
Yes, absolutely. I think for us, the one of the biggest challenges, in maintaining this holistic culture is that the patient populations, the regulatory frameworks, the revenue models, the staffing ratios have to be different. At least now, the way we're paid and the way we're held accountable by CMS, et cetera. And so these little mini cultures kind of develop. And we've had to really think about, like, is that okay? Is it okay for there to be, in hospice, I'll just use an example. In hospice, I think most of us are familiar with, like, these are individuals that are experiencing, the last days of their life. We have this bend over backwards ethos in hospice, and I think this is pretty common, where, we'll pretty much do anything that is, within reason to create the highest quality of experience in our hospice. We will bring in VR goggles, for a hospice patient to help them experience, being at the beach if they've never been able to see the ocean. Like, we will go really out of the box thinking. We'd love to be able to do that in primary care. but we're taking care of, 200, 250 patients per provider in that program. And in order for them to create that kind of access, they have to see 6 to 8 patients a day and, this many visits per month. And they just can't do everything. They have to have boundaries. They have to, we have to talk about it. We have to talk about what can we and can't we do. And it differs across service lines. And really that's all about, again, the regulatory frameworks, the really primarily the revenue model, et cetera. So, it's something that we have to talk about and think about. And then we have to also identify what are the areas where we can gain efficiency by standardizing and cross-training.
Can I just come back on that? Because I think you articulated that so well, Rebecca. That really resonates. I think one of the advantages of diversifying is at least it gives you the option to, couldn't agree with you more. Each service line or program has got to stand up on its own merits and has got to fit within its own regulatory framework and meet its own standards, etc. But I think there's an opportunity, if you've diversified well, to maximize those economies, particularly in the back office and in some of the support roles, but also in terms of protecting the workforce, as you were talking about with that resilience. You can use it as a way of keeping good people in the organization. If you're having to be more efficient in one area, you can still keep hold of them by reutilizing their skills in another area, so you don't lose them entirely. But also, I think potentially if you've got income from a number of different sources, you can soften those boundaries. At least they're semi-permeable. So whereas other providers maybe wouldn't be thinking about that and would be, much more about each area delivering, I think we've got an option if with our values and with our vision to actually do some creative stuff around the margins, which I think potentially for profits wouldn't be thinking about doing.
That's well said. Well, Mark, then let me ask you the next question. How do you cultivate leadership and management capacity, and maybe I should say competency as well, within your teams to handle such a diversity of services without burning them out?
I think that's really tough, and I think I have to hold my hands up and say at times I've run things pretty hot and relied very much on people's sort of commitment to the patient and the family to sort of see us through some sort of difficult periods where we're adjusting to taking on new services and stuff. I think, there is risk involved in the things that Rebecca and I are talking about. There's no getting away from that. And sometimes you have to rely on goodwill and people's commitment to get you over a hump and to get you through an early stage, or at least I have not been clever enough to find a way of not falling back on some of those things. So some of that comes back to the vision and the values and how well you've conveyed that. So hopefully you've got people that buy into that and for a period of time are willing to give it a go and to try and make it work, as long as you've got a clear plan to stabilize and sort of secure that going forward. I think investing in training and education is something that's so important, and rotating staff both across programs but also across organizations where that's possible as well. We have a similar situation to what Rebecca said about robbing Peter to pay Paul and people bouncing between the hospital and community and primary care and hospice. And actually the more we can do that in a joined up way, where actually we're enhancing the skills and the experience of those individuals. So our doctor training program, for example, involves hospital and primary care doctors coming through and spending time in the hospice, which enhances our workforce, but also takes away that mindset into whatever specialty they end up working. They've got that palliative care knowledge to fall back on. And then I think there's a commercial reality around this as well. So sometimes you've got to bring new people into the organization. You've got to get new people onto the bus. And then it's about building those relationships and about talent finding and about, whether you can identify the right people that are going to got the right values to adapt to a hospice palliative care environment, but maybe bringing a different skill set and coming from a different sector. And I think that's something we've been really successful with at St Helena. So leading our clinical program now is not a palliative or a hospice professional. It's someone that started off in a primary care role. And we wanted that different perspective to challenge and be a critical friend within the team. So I think sometimes the way we've approached that is consciously to bring people into the organization with a different perspective, with a different skill set, but with the same values.
Rebecca, I know this is an area you've given a lot of thought. It just, how to do the culture thing, how to get your managers, your leaders prepared to navigate a much more complex environment, just a monofocus than a just monofocus hospice. How have you done it?
Yeah, I mean, I would agree that with Mark that, I've had times where I feel like a complete failure at this. It is one of the things that I feel like I spend a lot of my waking hours worrying about. My approach has been related to the structure of our leadership team, and what's been most effective is to have these different tiers of leadership, and to be really intentional about roles and responsibilities at each tier. So we have an executive team of organizational officers that work across all three service lines. And those individuals have a lot of experience in leadership and actually have a lot of clinical experience and understanding of the three service lines. Below that, we have service line directors who are responsible for program strategy, finance, and a lot of external relations related to their specific service line. And then we have service line managers who really focus on executing the operational strategy, and the program supervisors then who support daily operations and HR functions. And then recently we added another level, which is a system of program or service level leads. We call them like hospice lead or primary care lead. And they're focused on providing mentorship. So they don't have HR responsibilities, which kind of levels the playing field, but they have more experience than maybe some of the other clinical staff. And they provide mentorship to the frontline staff, and they help with onboarding new staff, which then this structure relieves each level of having to do all of that, right? So I think it gives the staff a feeling of like, I don't just have one supervisor who also has the ability to hire, fire, do performance manager. I don't just have that one person that I can talk to if I'm struggling or if I need, a new idea or support in some way. And then it also cultivates skill development among our leaders and can create a career ladder opportunity. The other thing that's been really important is that in addition to that structure, we also have managers and directors that are supporting like more centralized functions that are not exactly standardized, but we get economy of scale by creating, like, for instance, a quality director, quality and population health director that works across all three of our clinical service lines, and IT support, an IT manager, and marketing, business development, communications director. So those individuals become pretty sophisticated in understanding all three service lines, but they're not experts, because what they do is they collaborate with the leaders in each service line to make sure they have the right content knowledge, but they actually then remove a lot of the like actual heavy lifting in those functions from the directors and managers and supervisors in the service lines. So that's kind of how it's really been about structure.
It's a shame we're not doing the 4-hour version, because it would be great to get our organizational charts and talk about the similarities and differences. That's brilliant hearing you talk about that.
I agree. In fact, we're going to absolutely have both your contact information, because I have a feeling people are going to want to follow up. Rebecca, that is absolutely brilliant. How long, like, what of a runway? Because I could see like that playing out. Has that like been a 3-year period or much shorter runway?
No, it's taken about 8 years to put that in place.
Wow.
The entire time I've been CEO, it was a really big problem when I came on. There just wasn't enough leadership support at all, to be honest. So it's expensive. I mean, I think that's the other thing is like it requires the business. We had to grow and bring in more revenue to be able to support this. But I want to say, in case any of my leaders are listening, and I say this probably at least once a week, but I do now have the most incredible leadership team. And they are I mean, they are everything. I can actually go on vacation and be completely disconnected from my cell phone. And I know, like, they will support the organization. And if one of the leaders is struggling, they help each other. It's really a family. And but it took years.
Wow. Well, Mark's so right there's so many rabbit trails we keep going, but we've got about another 15 minutes and I want to really hear from both of you on this question. So maybe Mark, if you'll be prepared to go first, if you were advising a hospice CEO, let's say UK or stateside, considering of going, man, I love what they're talking about. I want to create this beautiful continuum, multiple service lines myself. What's the mindset shift they need to make, and maybe 1 or 2 or 3 practical steps that you would recommend to them?
So I think the mindset shift is just being clear about the intention behind that. So even if that's a sort of an interim goal, what is it that they're hoping to achieve by making that step? What is it that they were inspired by to want to think, okay, I want to do something broader? Is it focused around the sort of the workforce piece? Is it around the financial resilience and the sort of commercial diversification? Or is it as part of a step towards sort of an ACO or, a better approach to a particular population? I think then you can sort of break that down into, how do you eat the elephant? You can then start to sort of break that down into sort of manageable bite-sized pieces. So I think that's important. I think in terms of practical steps, I think having a financial buffer is absolutely key, because, unless you're very lucky and things fall into place really well for you, you're going to have to invest up front to be able to realize the opportunity. So being clear about what you can afford to do in terms of the level of risk and the risk appetite of your board, I think is really important to get that clear up front. And then I think the sort of the talent and the skills side of it, and the sort of the leadership team, and whether you've got the in-house potential to develop to make that happen, or whether you need to partner or bring in someone new to take that forward. I think those would be the sort of first steps I'd advise thinking about.
Good employers know that health benefits can make or break your business. But while employers are looking out for their employees' best interest, who is looking out for theirs? Sona Benefits is an independent pharmacy benefit manager who partners with employers to optimize their pharmacy benefits while supporting their business goals. But by offering no-spread pricing, contract guaranteed rebates, and the Sona Max program, clients are regularly able to save 20% to 35% off their total drug spend. The result? Pharmacy benefits that improve employees' well-being and employers' bottom line.
That's really good. Mark, Rebecca?
I absolutely agree with you related to the hiring potential. I think one of the biggest pieces of advice I would give a hospice CEO who is diversifying into, let's say, home-based primary care, don't assume that your leaders are the right leaders to do both. I think bringing in some kind of expertise, even if it's a consultant, just giving. And I also think that, if you do it right, that will help your leaders not feel completely overwhelmed and stretched thin. They're different enough in terms of compliance and quality, and most importantly, revenue and the payment models, that you really need that expertise. The one thing that I think I would also say is that, once you start developing these other service lines, you really have to intentionally think about how to foster understanding and empathy between the service lines, because they are different enough that mini culture concept that I brought up earlier can become damaging if you're not careful. And so we've been very intentional about exposing all of our service line leaders and staff to the other, to all service lines, and really even like the structure, how the structures are different and how the payment models are different, so that they understand why, primary care can only spend 30 minutes with their patients and hospice can spend 2 hours. What's underneath all of that makes it important? One of the things that we do in our monthly leadership meetings, and this was really the brainchild of my COO, is that we have this template that we ask our leaders to follow when it's their turn to report out on their specific service line. And the template asks each leader to describe not just what they're working on in their respective area, but what the general feeling is among their staff, what wins or insights they've recently had, what accomplishments have occurred, what they're concerned about, and what barriers they're experiencing. And this has led to generating this really authentic dialogue between the leaders and some of the, even the like supervisors and managers, that results in just a better overall understanding and empathy across programs.
That's so good. And a follow-up question, and either one of you or both of you could actually take this. Rebecca or Mark, I wonder, chicken or egg? Like, if I have a business idea, do I then go find the leader, or do I find the perfect leader and go find the business idea? Is it the chicken or the egg sometimes? And then the second maybe question anyone you want to take is, I bet your dashboards are fascinating across these multiple businesses.
Yeah. Mark and I may differ. Mark, it sounds like, Mark, you have an entrepreneurial background a bit more than I do. So I would actually think strategically about what business line makes the most sense to expand into, and then I would go look for the leader. What about you?
I'd say have the chicken and the egg.
I love that answer.
I've certainly done both, and both can work. Yeah.
And then what about the dashboards? I'm curious for both of you. Mark, why don't you go first? Like, so many, office cleaning business compared to your hospice program, compared to your, what I would call kind of nursing in the home business. Do you have very diverse scorecards and they roll up, or they're just very much managed at that local business level?
Yeah, some similarities to what Rebecca sort of described, actually. I think that there are some sort of very tailored KPIs and requirements, and, some of the sort of commercial underpinnings of the businesses are quite different. So the reporting does need to reflect that. But then there are elements that do feed up into overall conversations. And when we're doing our sort of performance management and our financial reviews, we very much bring all of those leaders together. So you've got all of your professional support services, you've got all of your fundraising philanthropy staff, you've got your commercial non-care business leaders, and you've got your different program clinical leaders. They're all coming together when we're doing our business planning, when we're doing our budgeting, when we're doing our strategic planning, because we want them to have that awareness of what's happening around the organization to do the cross promotion, but also because I think what we're increasingly find is, as you diversify, the next phase of diversification gets progressively easier. And really what you're looking for is new magic windows of opportunity that emerge from the areas between your different service lines.
Ooh, that's a key point. Well, Rebecca, let me ask it to you this way, because I'm reflecting. I've been in a meeting this week, one of our very diversified hospices we work with. But here's the interesting thing. When hospice pays the bills, it gets the airtime on the KPIs and the planning, and then everything else, it's not an afterthought, but it's got potentially that risk because the main economic engine is the one that's paying the bills. But it's interesting, you grew up a much different way. You didn't start off as a hospice. So I'm curious your answer to the dashboard KPI question.
We have a lot of dashboards, but we have one dashboard we call our executive dashboard, that the most important KPIs from each service line roll up. And it's the executive dashboard, which I use with my board and also my executive team, has, as an example, has revenue, expense, cost per patient, revenue per patient, all combined. So you look at that first, which I think is intentional. I mean, it's just intentional at that level of our board and our executive leadership team. It's like, we got to look at the whole. The whole is what we're really focused on. And then it drops down and you see those various KPIs for each service line. So you can see sort of what's contributing to the whole, but we always start with the whole organization dashboard. The other thing that's really important to us is our engagement survey results. We do an annual engagement survey across the entire organization. And I can see how the organization as a whole is performing, but I can also filter that by not only just each service line, but I can look at disciplines. So I can look at our nurses, I can look at our social workers, I can look at our physicians, I can look at our aides, I can look at our office staff. I can also look at what's happening in leadership versus frontline staff, or how are engagement results for people who've been with the organization just a year versus those that have been 5 years or more. And so because workforce is so important to us, we really focus a lot on our engagement survey results and our turnover stats. So we can do the same with turnover. We can look at where are we having more of an issue with turnover. And then, what's great is because my leadership team is so close, then they can share, tidbits about like, okay, when we had that challenge with turnover, this is what we did, and it seemed to really help.
You're both just like, we're sitting here reflecting. You're both like a deep book, and I'm just having to skim over the surface, and that sucks because you have so much to share. So in that spirit, maybe Rebecca, you go first. Final thoughts. There's a lot that we've covered in a short period of time. I'd love to hear both of your final thoughts and maybe advice to those that are listening to the show.
Yeah, I think in summary, we've been very transparent and authentic about how complicated it is to run an organization with multiple service lines. In the end, the positives and the strengths outweigh the risks. I really believe it is the right way to run advanced illness practice in this day and age, and I think it makes us stronger. The diversification of revenue is just one part of that. I think workforce resilience, I think innovation, creativity, I think brand. I mean, we are definitely very unique in the marketplace, and it's a differentiator for us to be able to say that we actually provide a continuum of services, that starts with primary care, palliative care, hospice, and now we're actually starting to develop a more of a point of care testing line of business where we're supporting one of our payers and going into the home and getting some of the gaps in care, clinical care. So we're using, we actually just purchased mobile DEXA scanners so we can go into individuals' homes who've had a fracture, like older adults, primarily females who've had a fracture. And we can actually do, if they can't get out to get their bone scan, density scan done, we can do it with a mobile device. We're doing retinal exams, retinal diabetic eye exams, also with a mobile device. So we're starting to develop that. And again, like for me, that was very intentional. Looking at what the gap. I think Mark talked about this. Like, what are the gaps in care that we could fill? And we learned about those by serving the population, understanding like they can't get out to get their retinopathy because they're mobility impaired. Or
wow.
So anyway, I took a little
That's actually a good one. That's a really good one.
Took
and
a
I
little
love
road off, but
that I think, imagine does the word innovation like just very fluent in your culture, Rebecca, or is there a different way you describe that? Focusing on the patient and then what results in what I would call innovation. Do you talk about it a different way?
I think we talk about it in a number of ways. At the leadership level, we probably talk about it related to clinical innovation, but I think at the more like direct patient level, it's more about like what gaps are you identifying? Where are your patients not getting care that they need?
That is actually a brilliant answer. At some point, I'll tell you about Tom Foster, who's been in our show a couple of times. And your lexicon of levels of work is a whole body of knowledge, and very few people know what you're poking on. And one of the things I picked up from him is, because I love language painting the picture. But when I paint the picture, big picture, you have to speak it a different way depending upon the level of the organization, which is why every organization, we have communication issues. It's almost like you have to translate. And so your answer is brilliant on a whole different level. And Tom Foster is one of the few people I ever heard talk about that. And it's a funny way he talks about it. He goes, you talk about your big picture. But then the staff is like, what the hell is he talking about? And you have to translate in a way that's the language that they understand on a day-to-day basis. So, Mark, I'd love to hear your final thoughts as well.
Yeah, so just pick up on the innovation point quickly. I think because we don't tend to talk about innovation, although I think we are an innovative organization. I should have said our values are bold, passionate, and caring. And it's our passion to provide amazing caring that enables us and encourages us to be bold. So when we talk about being innovative, what we talk is let's be bold. And I think the sort of that is grounded in the fact that hospice is both special and also hugely transferable. So, all of the things that make hospice care special are relevant to bigger issues within our healthcare system and bigger social issues and problems that people face around looking at not just the individual but their family, about thinking about what's important to individuals and what might be right for one individual isn't right for another, about thinking about the value of home-based and community-based care as opposed to the expense of hospital care, which often doesn't deliver the same outcomes and the same experience at end-of-life care. So there's a specialness in the personalization, the holistic approach, the coordination, the focus on the family, the focus beyond just the medical condition that hospice brings, that wider population of people living with frailty, living with dementia, living with progressive illness would benefit from being able to access. And equally, there are the sort of the skills, the principles, and the business case to apply those hospice principles on a bigger scale and to benefit the health economics and the outcomes for a population on a bigger scale. So I think my advice would be, don't be afraid to be bold and brave. If you're in hospice care, you're in a great starting point to have impact at a even bigger scale, which will be great for, reinforcing the sustainability and the reach of your hospice program. But actually your hospice program could be doing so much more good for your communities as well if you embrace that. So I think there's great opportunity there. I think in terms of advice, I think just don't lose sight of not just thinking about the clinical side of what you do, but the opportunity to integrate the philanthropy and the community relationships and the public health approach and, the engagement type activities that Rebecca was giving a great example of. That is just as important as what you're doing on the clinical side, and they are entirely complementary. They don't have to be at odds. And the more you embrace that positive relationship between them, the stronger your overall programs and your reach will be.
That's so good. Well, thank you. I've learned just sitting here listening to both of you. Again, I think we could do this for hours. Maybe we'll figure out how to do a part 2 something, whether, Mark, maybe we get you to the stateside and, maybe sometime in the future. My guess is at a minimum, you two are going to talk again because there's a lot of synergy, but then your different approaches. Again, I've taken a page of notes just listening to both of you because there's so many great pearls in your answers. And it's interesting, I underlined it 3 times. What strikes me as necessity is always the mother of invention, thinking about the model you had to create, Mark, but then the way Rebecca created it in a totally different way. And then mission focus just keeps coming back to me. I've had this sense that going back to Jim Collins' good to great, the wisdom is like, we need to relearn that. And it's actually some of the wisdom you're poking on in some of your answers. Things that have now become cliche about first the who, then the what, get the right people on the bus. What is the hedgehog concept? Technology is an accelerator. Things that have become cliche that if you go back and pull that out, oh, someone wrote a book about some of this stuff. So I've been kind of on this kick of going, what is old is new. Let's bring that wisdom back. And whether you two know it or not, you exemplify a lot of the principles that he was actually teaching in that book. So hats off to both of you. You're both a treasure. And thank you for taking the time to share some of your wisdom. So again, glad to have both of you.
It's been a pleasure.
And to our listeners, we really appreciate you. At the end of each episode, we always want to share a quote, a visual that'll create like a brain bookmark, like a brain tattoo. That's a thought prodder, almost a summary of what we talked about today. We're looking to further your learning, and hopefully it'll stick in your brain. Please be sure you subscribe. We're going to include Rebecca's contact information, Mark's as well. And then we're going to go ahead and leave you now with our brain bookmark. So thanks for listening to today's show. Here's today's brain bookmark.
Leading organizations with multiple service lines is like going from basic math to trigonometry by Chris Como.